This will be the 15th presentation in the PRCP webinar series for healthcare workers. Today's webinar is entitled Meeting the Need for Connection by Enhancing Positive Interactions. It is my pleasure to get to introduce the two presenters for today. Tara Resnick is a psychogeriatric research consultant at North York General Hospital. Tara has extensive knowledge and experience in both long-term care and community sectors. She has a passion for dementia care as well as supporting frail older adults and their caregivers. Lindsay Stacey is also a psychogeriatric research consultant at Vibrant Healthcare Alliance. Lindsay worked in acute care as a behavioral consultant and also previously worked as a PRC within the Mississauga-Halton region. Lindsay has many years of experience working in the field of geriatrics, including case management and transitional support. And with that, I pass it along to Tara and Lindsay.
All right, thanks Mario for your introductions and welcome everybody. All right, so just a few housekeeping items before we get started today with our topic. The slide deck that you see on the screen will be shared with you shortly after the webinar. So feel free to sit back and relax and enjoy the presentation. Also, this webinar will be recorded and posted on the RGP Toronto YouTube channel. So then you can watch it back and also send it out to your colleagues who might have missed it as well. If you have any questions as we go along, feel free to utilize the chat room and we'll try our best to answer all the questions at the end. We'll also try to respond in the chat box if we can't get to it in the question and answer period. We also recognize that there might be some case-specific examples that you want support with or that may require further resolution. But unfortunately, because of time, we're not going to be able to address those cases. But we do encourage you to connect with behavioral supports, whether that's internally or externally to wherever you work to get further support. Okay, so the goals for our session today, our goal is really to identify a person's basic human need for connection. We're also going to discuss the main principles of pro-attention plans, as well as explore some strategies to enhance our communication with persons living with dementia. So first, we want to get to know you guys a little bit more, the people that are watching our webinar today. So we're going to launch a few poll questions. You'll see them come up on your screen. There's 3 of them. So the first one is, what is your role? And if your role is not listed as one of the options, feel free to put other and then write in the chat box what your role is specifically so that we can capture that as well. All right, so on the screen we have the results. So we have 27% are nurses on the line today. We have 9% as occupational therapists. We have 18% PRCs, 36% administrative, and then we also have 9% as others. So again, if you have another role, please put it in the chat. Our second poll question is, how many years of experience do you have working in the field? Okay, so we have the results for this one. We have 18% have 0 to 5 years experience. 24% have 11 to 15 years experience. 24% have 16 to 20, and 35% of you have over 21 years of experience. So definitely a wide range of years of experience, which is amazing. And then we'll see the third question come up. So have you attended any of the previous webinars in this series? Like Mario mentioned, this is our 15th webinar. So let us know if you've attended previous webinars. All right, so we have 63% have been to other webinars, which is awesome. Welcome back. And 38% have not, and that is okay. Just a reminder, they are on the YouTube channel, the RGP YouTube channel, so feel free to go back and check those out because there's lots of great information there. And I just want to acknowledge all of the years experience in the room. As professionals in the healthcare field, you all come to this webinar with so much experience already and from so many different backgrounds, and we really want to acknowledge that. So as we go through the slides today and through our presentation, feel free to comment in the chat box, share your experiences and your knowledge, because we all learn from each other. As you saw, there's lots of years of experience in this room today, so we want to hear from you as well. All right, so before we jump into the content of our slides, we're going to do a Mentee poll to start things off today. If you haven't used Mentee before, all you have to do is open a new web browser, either on your phone or your computer, and type in www.mentee.com. It's going to ask you for a code, and that's shown at the top of your screen, and we're also going to write it in the chat box. So the question we're asking today is, thinking about yourselves personally, what are some of the things that you do when you're looking for connection? I also just want to remind everybody that all of your answers are anonymous, so we can't see who wrote it. And if you can't access Mentee, you can also just write your responses in the chat box, but it won't be anonymous at that point. Okay, so we're getting some answers coming up here. So some things that you do when you're looking for connection. You're searching on the internet, observing, listening to music, sense of humor, similar values, listening, maybe going to a party, thinking about those holiday parties coming up, networking, asking friends and reaching out, absolutely. So, you know, reaching out to those people around you to meet your need for connection, making plans to connect, showing kindness, having some humor, looking for support. Excellent. That's great. And when we think about connection, it is truly vital to our survival and our mental health, right? It's really wired into our bodies and it's wired into our minds. We're always seeking that connection. It's why we're here. It really gives us this purpose and it gives us meaning to our lives. And it's not just about those primary relationships that we often think about when we're looking for that connection, you know, through our significant others, our family, our friends. But it's also about other friendships and those varying degrees of closeness of friendships. It's our need for connecting with a group of people that we might consider a community, whether that's work colleagues or somewhere else. It could be spiritual connections, us contributing to other people, but also our need to connect to the world at large, right? We want to be fitting into society and sort of into the world and kind of exploring that. So we are connected on so many different levels. And if we're not connected in whatever way that sort of is meaningful to us, we start to feel disconnected. And I find that we often feel a little bit hungry for whatever is missing in our lives, right? So I want you to think about that, your need for connection. And then I want you to think about some of the older adults that you support. And is it any different? Is that need for connection any different? And no, it's not. It's the same, right? It's the same for older adults, same for somebody living with a cognitive impairment, and it's the same for us. We all need connection, and we know that older adults and people living with different diseases, they can become extremely isolated, they can become lonely. So it's almost even more important then that we ensure that they're able to stay engaged and find opportunities for them to interact with other people as well as the world around them. And that's really what our focus is for today on this webinar, is to explore some of those ways that we can help them feel connected. Okay, so one of the frameworks that we're going to be talking about and that we find very helpful in addressing a person's need for connection is through something called the 4 Ps. So the 4 Ps is a framework that reminds us of the 4 main areas in which a person has needs, and it allows us to check in with the person. So those 4 areas are pain, personal care, positioning, and presentation. And so how it all works is members of the care team are going to engage with the person usually around every 30 minutes if they can, and they're going to complete a consistent check-in. So the staff member will always ask the same 4 questions, and again, they're focusing on those 4 Ps that are on the slides there. And Tara's going to go into more detail on those in just a moment. And when you're going into the person's room to do a check-in, it's important that we want to be mindful that if the person is sleeping, that we don't want to wake them, right? Of course, we would want to allow them to continue to sleep with no interruption, so we would just leave them be. There is a 4P log that the team can use to track their check-ins, and usually that's kept in a spot that is accessible to all the team members. So for example, it could be left in a communication binder, it could be left at the nurse's station, in the medication room, wherever the team can have access to it. And that way each team member can check off when they've seen the person. And it also helps to prompt the team about what they should be looking for when they're going in to see that person. Okay, I'm now going to pass it over to Tara, and she's going to take us through each of those 4 Ps.
Thank you, Lindsay. And before we jump into doing our deeper dive into each of the 4 Ps, I'd love to remind everybody on this webinar today of what I think of as a swear word, or a swear phrase, as you will, but this idea of what oftentimes we hear as, or labeled as, attention-seeking behavior. Again, I call that a bit of a swear phrase because we want to always stay away from saying that, but also viewing the people we support as attention-seeking, because what may appear as simply a need for connection is likely more a need to have something going on with the person, that unmet need, if you will, met. And that's what we want to talk a little bit more about as we dive into the 4 Ps. So let's start with the first one, pain. So if you've been to my past webinars, you know that pain is sort of one of the first things I love to rule out. The staff I support often laugh at me and call me the pain police, because pain is one of the most common causes for a lot of the behavior we see in older adults living with or without a major neurocognitive disorder. And the reason for that is, there's many reasons. So we all have very different thresholds for pain. Dependent on our cultural beliefs, we may view pain differently, or the treatments for pain very differently. Or, of course, there's the idea that we may not be able to verbalize our pain. So we're going to show our healthcare providers, if that was the case, that we're in pain through our behaviors, through our actions. So when we think about ruling out pain as what's causing this person's behavior, we want to think about a couple of things. So we want to make sure we're asking both closed and open-ended questions. Being mindful of the fact that, again, some people may be nonverbal, they may be experiencing aphasia, which is that loss of language, and therefore may not be able to communicate with us using language, or they may have a language barrier. A reminder that we live in the most multicultural and diverse city in the world. So this is often a barrier that we may be faced with when we're trying to communicate with the older adult we're supporting. We may speak different languages. So we want to try to use closed and open-ended questions using things like communication cards, if we have any. A reminder that you can always reach out to your behavior supports teams or your PRCs, and we can access communication cards for you if that's something you need to utilize. And then we also want to remember that there are definitely various ways to assess pain. So we want to think about things like our best practice tools. So thinking about different assessments like the PAIN-AD, which stands for Pain Assessment in Advanced Dementia. And this is a tool that's used by observing the person you're supporting, so that resident patient or client, for 5 minutes before actually scoring them on this assessment. So you're really using your observations to assess their pain, or thinking about using something like the Abbey Pain Scale, which is an assessment that's designed to assess pain in people who can't express their needs at all. So these are all available to you online, and we also want to remind you of the RNAO best practice guidelines surrounding assessment for pain as well. Really good resources to access. Again, we want to remember that what may seem like the need for connection may actually be the need for relief from pain and discomfort. So asking questions like, how is your pain, or does it hurt anywhere? And then letting the person guide your next steps based on their responses is really important. So moving on to the next P, personal care. We want to always consider the need for personal care. So when we think of personal care with the older adults we're supporting, we want to consider things like toileting. Does the person need to toilet? Are they in an incontinent product or brief that may be soiled and needs to be changed? Again, when we think about the behaviors we'll see as a result of this, it may actually present, or they may actually present rather, as this need for connection or this need for attention, but it may actually be a need to have that product changed or to use the toilet. Is the person hungry or thirsty? When we think about ourselves, we're able to grab something to eat, or we're able to grab something to drink when we're hungry and thirsty. But if we were an older adult living with a neurocognitive disorder or mental illness or other diagnoses, we may not be able to do that. So what we would do is we would show you that we are hungry or thirsty using our behavior. A really easy way to rule that out is to ask the question. If the person is unable to answer the question, use cues, visual cues. So, instead of saying, would you like some water, hold up the water and say, would you like some water? Therefore, you will always have that backup plan. So if the person is actually unable to say, yes, please, I'd like some water, they'll at least see the water and they'll be able to point to it that way. I want to also take a moment to think about clothing and temperature. This is a big one. I had a resident when I worked in long-term care who was disrobing in public. And of course, the first thing I heard was that this gentleman was, quote unquote, socially inappropriate, another swear phrase, if you ask me. But what was really happening is that he had gained weight. So that's in long-term care, but even in acute care or community, when somebody starts to get support, remind ourselves of the fact that they're probably eating more than they did when they were living alone. And as a result, they're going to likely put on weight. So this gentleman's clothing wasn't fitting anymore because he was in a long-term care home and he was eating 3 meals and 3 snacks a day, which is more than I think a lot of us eat on some days. And he was taking his clothes off. He was unable to say, my pants hurt, they're too tight. So he was just taking them off wherever he was because he was living with dementia and he wasn't feeling good. He had discomfort because his pants were too tight. I'll never forget that when we actually looked into that piece, rather than just assuming this was quote unquote socially inappropriate behavior, the poor gentleman had marks on his stomach from where the pants were digging in. And you know, a lot of these things, I just want to say, they may seem pretty basic, but as healthcare providers, sometimes we forget to look at the basic things, and we jump to the most complex or complicated sort of issues rather than also ruling out those basic things. So we got him some clothes that fit him, and the behavior never presented again. And most importantly, I might add, this gentleman was comfortable in wearing clothes that fit him. And then likewise, thinking about temperature in the room. So if it's really hot, we know as people who are living without any sort of neurocognitive disorder that we can take a layer off, right? Or we know to dress appropriately for the weather. Conversely, if it's really cold, we know that we can layer up, put on a jacket, whatever it is we need to do. But if we were, again, living with that diagnosis, we might not be as cognizant of these things, and we also likely wouldn't you know, be able to take a moment to say, hey, Lindsay, I'm really hot. Can you help me change into something lighter? Or, hey, Lindsay, I'm really cold. Do you know if there's a jacket or a blanket around? So what I would do is I would either show you with my behavior, and that would look like things again, like disrobing if I'm too hot, or maybe putting on layers and layers of clothes rather if I'm too cold. So when we are trying to meet that need for connection and ruling out those underlying causes, these are things we need to consider as well. And moving on to the next P, positioning. So thinking about the position that the resident, patient, or client that we're supporting is in. So sometimes this is as easy as doing a quick environmental scan, looking around the room to assess their positioning. So are they comfortable? Are their pillows comfortable? I don't know about you, but if I sleep with too many pillows or in an awkward position, I am not feeling great the next day. So we're starting to see how these P's also tie into each other, because my positioning may have been off and I'm going to be experiencing pain, and that's pretty severe pain. If you've ever woken up with that stiff neck or back, you know that it ruins your whole day. So I'm able again to say that and to treat that myself. But if I wasn't, we would need someone to advocate for me. Thinking about likewise their position in their chair, so their wheelchair or the chair they're sitting in and in their bed. Are they comfortable? Are they in an awkward position? Could this be why they're calling out for a need for connection? Again, this idea of offering extra blankets, which ties into personal care as well. Changing angles in the bed or chair. Again, I always think of myself, not to make this all about me, but I am a stomach sleeper, and not a lot of people are. So I hope if the day comes where I am older and living with a neurocognitive disorder, I'll have someone in my life to advocate for me who can say, Tara's a stomach sleeper, make sure she's sleeping on her stomach, because if I'm not and I'm not getting any sleep, you can be quite sure that I'm going to have a lot of behavior, and what's going to be looking like, again, that quote-unquote attention-seeking behavior is likely more just me needing to get a good night's sleep or needing to be repositioned in my bed. And then think about the location. Can they see a window? Can they see the door? Can they see the clock? Can they see the TV? Sometimes these things are easily missed, and as a result, the person is going to need to connect with us to change this, and they may not be able to tell us. So we can ask the question, are you comfortable? Oftentimes, if someone can or cannot communicate with us using language, they can still use gestures to let us know what it is. One of the homes I support, actually, we were just working on a case last week. I can share this example. They had a resident who was, for all intents and purposes, not able to communicate using language. Her command of language was quite minimal, let's put it that way. And staff got to know her so well that they realized when she says, uh-oh, she means the TV's off and she wants her favorite show to be turned on. And they even knew what her favorite show was. So, you know, it's asking these questions. If you're in acute care and you don't have the time to get to know the person as much as you would if you were in long-term care, as an example, asking questions if they have any friends or family members or anyone really in their life, any loved one who's able to let you know what they love, what they don't love, because these are things that can help us when we're trying to rule out those needs for connection as well. Thinking about, again, where the clock is. Some people like to see the time. How about the date? Is there a calendar we can get on the wall? Is there any sort of thing we can use in their environment to help them feel oriented, to help them feel comfortable, to help them feel safe, to help them feel less anxious? Because this is also going to minimize a lot of the behavior we see. And then lastly, we want to think about presentation. And you'll hear us talk about this all the time because this is really important really when we're thinking about supporting somebody living with a major neurocognitive disorder in general. So we want to first and foremost make sure that we have all the items they may need within reach. So is the call bell within reach? Imagine, if you will, for a moment, if you needed your call bell, a way to communicate and get your needs met with one of your healthcare providers, and it was just without reach and you couldn't do anything about that. I want you to imagine the frustration you would feel and what you might do in an effort to get that call bell. Maybe you'd reach for it and extend too far and you'd fall. Maybe you would call out. Maybe you would swear and scream if that's what you had to do. Maybe you would grab onto the healthcare provider's clothes when they finally do come to your room to try to get their attention, to try to communicate what it is you need. This also is true of thinking about things like their bedside table. What's on it and what needs to be on it? And again, I want you to think of yourselves. What do you have on your nightstand every night before bed? And what do you need on that nightstand every night before bed? That likely won't change. You may add to it. You may have some small changes as you age, but what we need is what we need. It's personal to us. How can we make sure that the older adults we're supporting have that set up for them as well? Are they the kind of person that needs to have a glass of water or snacks at their bedside? I'll tell you right now, I absolutely will be. So that's easy for me. Get it into my care plan. Always make sure there's a fresh glass of water on my nightstand and probably something to munch on because that's something I need to feel good. And then mobility aids. So again, this may seem pretty obvious, but let's make sure every time we leave that person's room, if they do require the assistance of any sort of mobility aid, is it within reach? Is it somewhere where they can at least see it and know it's within reach to help them feel safe and secure should they need it? These are things, again, when we think about ourselves that we all need. Thinking about removing any unnecessary clutter. So unnecessary clutter can impact that person's needs in so many different ways. So maybe if they see too much clutter, they've just lived their whole life liking a neat and tidy space, and it's not making them feel really good. So maybe they need to be in that uncluttered, sort of neat and tidy place. Maybe if they see too much clutter, they may think they might trip and fall. If they're a person who has insight and understands that they are at risk for falls and have fallen in the past, it may actually limit their mobility in that they may not want to get up and walk around because they're too anxious or concerned that they're going to fall. Thinking about, all the different ways in which clutter might impact that person, because the list really does go on and on. And then thinking about lighting. We know that lighting has a very powerful impact on how we feel and on our mood. So are the curtains open? Is that something the person would like? Are they closed? And is that something the person did because they are maybe living with a mental illness like depression and they want to be in the dark? Could we maybe encourage them or motivate them to try to open their blinds to let some of that natural light in to help them feel better, to help their mood improve even slightly, because light does that. Again, thinking about if they have insight into their abilities. If the environment is too dark, is that going to make them feel unsafe in terms of maybe getting to the bathroom, getting up to walk around if they're able to? Do they prefer the dark? Are they somebody who may live with migraines and have a history of migraines, I should say, and they're in a hospital with fluorescent lighting above them, and that's actually triggering something in them, and that's what's causing the behavior or whatever it is that that person is presenting with in terms of that obvious need for connection. These are all things we need to consider when we think about lighting. Is this person a reader? And are they maybe bored in the evening because they don't have a small lamp beside their bed and therefore they can't read and they're bored? Do they like to watch TV in the dark? So I could go on and on and on. In the interest of your time, I'll stop there. But lighting is super important, sometimes more important than I think we consider. Are they in a comfortable and familiar environment? This is a huge one as well. Again, I'd like to invite you to think about yourselves. If you are in an acute care setting, a long-term care setting, or in your home, would you want that environment to feel familiar? I think the answer for every single one of us, I think it's safe to assume, even though we tell you to never assume, I think it's safe to assume that the answer is yes. Because when we're in a familiar and comfortable environment, we feel safe. We feel secure as human beings. So can we make the acute care room comfortable? Yeah. Can we make it familiar? Sure. Because I know you might be thinking, well, how do we do that in a hospital setting? Ask their family to bring in a picture. Ask their family to bring in their favorite pillow. Ask their family to bring in, their favorite clothes, their favorite pajamas. Whatever it is that's going to feel familiar or feel like home is going to make them feel more safe, secure, and comfortable. Thinking about in long-term care, one of the first questions I ask the staff I support in long-term care is, what does their room look like? Does their room look like home? Because if it doesn't, I wouldn't want to stay in that room either. I'd be calling out all day and night too, because I need to feel comfortable and safe. And if I am already having cognitive deficits, I likely need as many familiar things as humanly possible in that room. So thinking about a bedspread, thinking again about bedding, thinking about my own clothes, TV, the music I like to listen to, pictures for my wall, anything that you can bring in from home to help that person's room feel like home will make a massive difference, that we can guarantee you. So we wanted to end off just by talking a little bit about enhancing positive connection. So we talked about the 4Ps, but what can we do to enhance positive connections with the people we're supporting? So at all times, we want to consider our nonverbal communication. And again, this may be something that seems pretty obvious, but it's also one of the things we forget most as healthcare providers. Because when we're truly honest with ourselves, we work in fast-paced environments where time is often limited. So as humans, it is easy to forget. So let's be kind to ourselves and acknowledge that. And that's why we thought it'd be good to refresh ourselves on this. So what is our body language like? Thinking about things like our positioning of our arms. Are our arms crossed? And are we sending the wrong message to the person we're supporting? Maybe, sending an inaccurate message that we're angry or we're frustrated or we're unhappy when we cross our arms. We know that we're probably just crossing our arms because we're comfortable that way, but the patient, client, or resident we're supporting may not know that. And we are therefore sending a very, very powerful nonverbal message that we don't mean to send. Thinking about things like standing with our hands behind our back. That can cause a lot of suspicion and paranoia in the people we're supporting because they may think we have something behind our back to hurt them with. Thinking about our tone of voice. Sometimes when we're supporting older adults, we just default to raising our tone because we mean well. We want to ensure that the person can hear us. But if they can hear us, we're just yelling at that point, and that's going to definitely send the wrong nonverbal message. Thinking about our facial expressions. Are we smiling? Are we squinting? I think of myself all the time because especially in these days when we're wearing masks, I have a hard time wearing my glasses because they fog up. If you wear glasses, I'm sure you can relate. So if I'm not wearing my glasses and I have a mask on and I have to see into the distance, I'm probably squinting. And I may be sending the wrong message to my colleagues, to anyone, to the staff I'm supporting. Really, I'm just trying to see, but they may think I'm giving them a dirty look. So I have to be really mindful of that. When we think about these things, even with a mask on in the current times we're living in, you can see someone's facial expression quite clearly with a mask on your face. So I want you to consider that next time you are interacting with anybody because it's pretty obvious what our facial expression is underneath that mask. And then thinking about our posture or stance. Even standing at a 45-degree angle with 1 foot behind us we will present as smaller, less threatening. Overall, we will send a very different nonverbal message. Again, thinking about where our arms are, where our hands are. I'm a very animated person, which I'm sure you can tell through my voice, but if you could see me right now, my hands are flying all over the place. That's just who I am. I'm very animated, but I have to be very mindful of that when I'm working with staff, residents, or patients, because they may think that I'm actually being aggressive when really I'm just being myself. So again, we are always well-intentioned as healthcare providers, but some of the things we do naturally may be sending the wrong nonverbal message and taking away from that positive connection that we're actually trying to establish with the people we're supporting. We want to remember to give a clear and positive introduction every single time we interact with the person. We can never assume, especially when we are working with folks who are living with memory impairment, that they're going to remember who we are. Even if you are working in the community or long-term care and you've been working with them for years, thinking about things like a status change, like delirium, thinking about a decline in cognition if they're living with dementia, thinking about just the fact that they may have short-term memory impairment, we can never assume that the person knows who we are. So by introducing ourselves and knocking on the door and giving that clear and positive introduction, you are guaranteed to ensure that you are sending them the message that you are not an intruder, you are not a threat to them. And by identifying yourself, they know that you're a healthcare provider and that you're safe and you're there to help them. And then lastly, we want to think about validation communication. So validation communication is this idea of meeting the person where they are rather than trying to bring them into our here and now reality. We know that people with major neurocognitive disorders it will never work with them. Trying to do what's called reality orientation and bring them into our here and now reality just won't work. So validating the person's feelings, emotions, experience, meeting the person where they are in their reality will guarantee a positive connection every single time. So lastly, we just want to thank every single one of you for supporting persons living with dementia and for the important work that you're doing all the time, but especially right now, as we are still living through this pandemic. You are the heart and soul of healthcare, and we just want to acknowledge that. We want to applaud you, and we want to thank you so very much for all of the work that you do every single day and the difference that you are making in older adults' lives. And lastly, we want to hear from you, so a survey will be coming out. We want to know if you thought this was helpful, so feel free to let us know if you didn't. And we also are curious to hear if there are other topics you would like us to see. So for future webinars, we always want to hear from you, and we're happy to present on anything that you need. And I will pass it back over to Mario.
All right, Tara, Lindsay, thank you so much for sharing your knowledge, your insight, and your experience on such an important topic. We are open for questions. We welcome all questions. Again, please select please select it for it to be all panelists and attendees for us to see your questions. I gotta say, the presentation really made me think about my own grandmother, actually. And when you mentioned the clock in particular, just that she was always somebody that had to be on time. And when she suffered a major stroke, and which left her nonverbal and paralyzed, the clock was very important to her. And I remember that if the clock struck 12 and the lunch was not ready there, because she's always on time, she would start to scream. And the caregivers knew that have things ready for her and everything would be okay. So thank you. You just reminded me about her right now with that story. Again, we welcome all questions. Please share any questions, any examples yourselves. We welcome all. But again, thank you for sharing that, because you definitely took me back there. I mean, I have to say, like, I mean, a lot of great examples, even when you talked about pain. Again, thank you for sharing that as well, because I can say in supporting the homes and agencies that I support, pain often comes up as a discussion around so I mean, here's something like, I mean, when you have members of the team that you bring up pain that could be a possible concern, how do you respond to members of the team that without doing an assessment would say, well, I don't think it's pain right away?
That's a great question, Mario. So personally, what I do, and then of course, Lindsay, I'll pass it over to you if there's anything that you do differently. But I always encourage staff, and we do this together usually because we'll do our knowledge to practice case consultations together. We look at the other diagnoses, those physical causes for the pain that the person is living with, because oftentimes what happens when we do that is the answer sort of jumps out. I was going to say jumps off the chart at you, but it does. I'll use it. I'll give you an example. I'll always think of this when we think about the other diseases the person might be living with. Again, back when I worked in long-term care, I had a resident who during the day didn't have any responsive behaviors. And in the evening, every time staff would help her get into bed, she was very happy, grateful to go to bed. She was tired. Everything went really well. And then as soon as staff left, she would be screaming and banging on the walls and banging on her nightstand. And we tried to rule out all of those usual suspects first. So is she hungry? Does she have pain? Is she scared of the dark? All of the things you would normally think of, those assumptions that we always say we shouldn't make. And what was actually happening is that she also lived with COPD. And when she was laying flat in bed, she was short of breath, but she only spoke Russian. So she was unable to tell us that. So that's an important detail I realized I left out. But so, it was so wonderful that we discovered that because we got it into the care plan to elevate the head of her bed every single time she wanted to be in bed. And she was never short of breath again. And of course, the behavior resolved, but most importantly, she was never short of breath again. So I know you asked me a question about pain, but sometimes what happens when we don't assume that it's the dementia that's causing the behavior, it actually helps us to look through a bit of a different lens and look at all of the other diseases the person's living with, and the answer sometimes jumps right out at us.
That's a great answer, Tara, because we talk about pain, but we also have to acknowledge discomfort as well. And different diagnoses can cause discomfort. And just to put a plug out there, the RGP YouTube site has a great webinar on the physical causes of behavior for anyone who's interested in checking that out. Because yes, definitely you want to rule out physical causes, whether it is pain or discomfort. So excellent example there. And I remember a case that I worked on too that was very similar. Person had COPD and was labeled as attention seeking because she needed to get back to bed following her meals. Lindsay, I think you wanted to add something to that.
Yeah, just quickly, Terry, thank you for saying all that, but also just adding in, asking, have you asked the person in other ways? Because sometimes we just say, Tara, are you in pain? No? Okay, perfect, right? So we walk away, but asking in a different way. So Tara, does this hurt? You could say ouch and sort of point to the shoulder or point to a specific body part. I think sometimes that works better, but I really just encourage my teams to, just go back and sort of review the med chart, talk to the doctors, see what other diagnoses they have, like Tara said, but also just keep asking because pain comes and goes, right? It could be here today. It might be not be here today. It could be here in 5 minutes. So it comes and goes. So we always have to be checking in and asking. And I think just using different words to try to capture that as best as we can.
And I just want to piggyback on that because Lindsay, you're absolutely right. Another thing we want to think about with pain when we're thinking about assumptions as well is that just because the person might be on medication for pain, it doesn't mean it's the right medication. It doesn't mean it's working. So sometimes what I notice is that staff will look at the med list and they'll see, Tylenol, PRN, can't be pain, Tara's on a Tylenol PRN. And what we want to consider is, first of all, does it need to be scheduled? PRN might not be the answer. But second of all, is it working, right? Because if I'm living with really intense pain, Tylenol might be the answer.
And really double checking, is the PRN actually being used as well?
Yes.
So key theme I'm hearing here is let's move away from assumptions and let our assessments guide our answers.
Love that. And I want to also say, because we've talked a lot about attention seeking, we also want to be mindful of our language, right? That's why we say attention seeking with air quotes, like we all do, because language is huge. And I invite everyone, if you haven't already, to go take the person-centered language pledge on the provincial BSO. I think it's on the Brain Exchange. Take that pledge, because the language we use is important. And, you know, thinking of things like attention seeking, I just wanted to sort of put that plug in. You'll get a little certificate when you take the pledge.
And there's many great resources when we think about person-centered language. And I think you really emphasize that we need to be describing exactly what it is that we're experiencing with the person, rather than labels that can leave a lot of assumptions. Okay, well, if there are no questions, I think we just want to say thank you to everyone again for attending this webinar. There will be another webinar coming up very soon on Tuesday, January 11th at 9:30 a.m. And it's going to be a very interesting topic on design and dementia. And it's most specifically going to be around wayfinding. So please, when the link gets sent out or the invitation gets sent out, please join us again for this very informative and very important topic to discuss in caring for our older adults with dementia. Again, just wanted to thank you all for attending today. You will be receiving a short evaluation survey and the YouTube link by email. Please, we welcome all suggestions from you for future webinars. We're interested in learning what you'd like to learn more about. And please stay tuned in your emails for future invitations to future webinars, such as design and dementia and wayfinding. So wishing you all a wonderful holiday season and all the best with great health for the new year 2022. And we look forward to seeing you again. Thank you.